Anaphylaxis is a severe, life-threatening, generalized or systemic hypersensitivity reaction. It is characterized by rapidly developing life-threatening problems involving the airway, so pharyngeal or laryngeal edema, and or breathing, so bronchospasm with tachypnea, and or circulation, hypotension with or without tachycardia. In most cases, there are associated skin and mucosal changes. Anaphylaxis typically is rapid and unpredictable, with variable severity and clinical features including cardiovascular collapse, bronchospasm, angioedema, pulmonary edema, loss of consciousness, and urticaria. So what happens in the body during anaphylaxis? When the trigger reaches the IgE on the cells, inflammatory substances are released. These cause blood vessels to relax, which makes them leaky and can cause swelling and a fall in blood pressure. At the same time, they can make the breathing passages become narrow and so make breathing more difficult. Anaphylaxis is an inappropriate and extreme immune response. It occurs as a result of exposure to an allergen to which a person has already been sensitized and previously made specific immunoglobulin E, or IgE. Anaphylaxis can occur on re-exposure to the antigen, when explosive amounts of histamine and other chemical mediators are released following the binding of the antigen to IgE-coated mast cells. So in this case, the antigen is the trigger. Histamine is just one of the substances released from the cells. Antihistamines are medicines which stop histamines from working. They are, however, slow to work and therefore not recommended as treatment for anaphylaxis. Antihistamines also don't prevent all of the effects of histamine. For example, the effects of histamine on the heart in serious reactions. Another thing to remember is that histamine is not the only substance released during anaphylaxis. The same cells with IgE antibodies on their surface release many other substances which can be just as dangerous. Antihistamines do not protect against these other substances. This is another reason why antihistamines used alone will not save lives in some really serious attacks of anaphylaxis. Adrenaline, or epinephrine, is the standard treatment for life-threatening anaphylaxis. It works against all the most dangerous aspects of anaphylaxis, not just those caused by histamine. There are numerous potential causes of fatal anaphylaxis. Some are listed here, but potentially there could be more. A number of people can also experience anaphylaxis when no cause is found. This is known as idiopathic anaphylaxis. Patients having an anaphylactic reaction in any setting should expect the following as a minimum: recognition that they are seriously unwell, an early call for help, initial assessment and treatments based on an A, B, C, D, E approach, adrenaline therapy if indicated, and investigation and follow-up by an allergy specialist. Sometimes a patient will present with symptoms mimicking an anaphylactic shock. Here's what to look out for. Skin or mucosal changes alone are not a sign of an anaphylactic reaction. Sometimes skin or mucosal changes can be subtle or absent in some anaphylactic shock reactions. There can also be gastrointestinal symptoms in anaphylaxis. Septic shock or asthma, particularly in children, can also present as anaphylaxis. A vasovagal episode, a panic attack, a breath-holding episode in a child, or idiopathic urticaria or angioedema may also mimic the symptoms of an anaphylaxis. Here are some conditions that mimic anaphylaxis. There is also a list of symptoms that they share with anaphylaxis and those that differ from it. Anaphylaxis is a medical emergency, and the approach to all critically ill patients, including those who are having an anaphylactic reaction, is the same. The underlying principle is to use an airway, breathing, circulation, disability, and exposure approach to assess and treat the patient. The ABCDE approach can be used irrespective of your training and experience in clinical assessment or treatment. The detail of your assessment and what treatments you give will depend on your clinical knowledge and skills. The signs and symptoms of a compromise in the airway, such as the airway swelling, may result due to swelling in the throat or the tongue. This in turn may cause difficulty in breathing and swallowing. The patient may feel a sensation that the throat is closing up. The patient may develop a hoarse voice or stridor. A compromised airway will cause problems with breathing. This might manifest itself as shortness of breath, an increased respiratory rate causing a wheeze, the patient becoming tired, confusion caused by hypoxia, cyanosis, and finally respiratory arrest. Problems with the circulatory system can show up as signs of shock, such as the patient being pale or clammy. It can lead to increased pulse rate and low blood pressure. Ongoing circulatory problems can cause a decreased conscious level, myocardial ischemia, and finally cardiac arrest. At this point, it is really important to not stand the patient up. Signs and symptoms of disability caused by anaphylaxis include a sense of impending doom, which may lead to anxiety and panic, and a decreased conscious level caused by airway, breathing, and circulation problems. Signs and symptoms of exposure during anaphylaxis are skin or mucosal changes or both. This may manifest as erythema, urticaria, or angioedema. Adrenaline is the most important drug for the treatment of an anaphylactic reaction. There are no randomized controlled trials, but there is consistent anecdotal evidence supporting its use to ease breathing difficulty and restore adequate cardiac output. It has multiple mechanisms of action, and it works best when given early. There are certain medications that can alter the effects of adrenaline when it is given for anaphylaxis. Tricyclic antidepressants may increase the effects of adrenaline. This is why it's important to start with a safe dose and monitor the response and give a further dose if it is required. Adrenaline can fail to reverse the clinical signs of an anaphylactic reaction in patients treated with beta blockers. The decision to prescribe a beta blocker to a patient at an increased risk of an anaphylactic reaction should be made only after thorough assessment by an allergist and a cardiologist. These are the adrenaline dosage guidelines as recommended by the UK Resuscitation Council. Patients should be made to feel comfortable, and there are many factors to consider. A patient with airway and breathing difficulties would probably prefer to sit up, as this makes breathing easier. However, patients with low blood pressure or those who feel faint should be placed in a flat position with or without leg elevation. Patients that are breathing but unconscious should be placed on their side in the recovery position. Pregnant patients should be placed on their left side to prevent compression of the inferior vena cava. It is important to remove the trigger of an anaphylactic reaction if possible. If not, however, you should not delay any definitive treatment. The main exception here is if you suspect food-induced anaphylaxis, it is not recommended to make the patient vomit. Sometimes cardiorespiratory arrest can follow an anaphylactic reaction. In this case, you should follow basic and advanced life support guidelines. You should start cardiopulmonary resuscitation immediately and follow current guidelines. There may be a need for prolonged resuscitation, so good CPR is important. Rescuers should ensure that help is on its way, as early advanced life support is essential. Once the life-threatening aspect of anaphylaxis has been treated, there is further treatment to be done in the hospital. This includes fluids, steroids, antihistamines, and a blood test. The blood test is for mast cell tryptase. This is the test that is used to establish the diagnosis of anaphylaxis. Blood samples for tryptase should be taken as soon as possible once the person has been stabilised and no longer in a life-threatening condition. Another after 1 to 2 hours after that, and then another one 24 hours later. Once the patient has been stabilised, and they should have a follow-up appointment with an allergy specialist. This is for the purpose of educating the patient how to avoid their known trigger and to assess whether there is a need for the person to carry epinephrine or antihistamine treatment.